All right, thanks, Dave. This is Dr. Bindlish, and I'm just going to lead a little bit of a question and answer. It's 7:38, and we would like to finish the webinar by 8 o'clock. So I apologize if we don't get to your question. There's questions, as I've been watching, are slowly filtering in. Some of the questions, perhaps, if we don't get to them, we can answer at a later date. The first question I'm going to pose to Dave. This came in a few days before from a patient, and just in the gist of it, so this is a situation where a patient has elevated eye pressure, a narrow angle, has had some treatment with an iridotomy, and is on eye drops, but there's always a concern that their family doctor or nurse practitioner wants to prescribe a medication that conflicts with glaucoma. And this obviously worries the patient. They refuse to take the medication. So how best can we address this concern?
Thanks, Raj. This is a question we get constantly, and it can be a little bit of an annoyance for us, for family doctors, and for patients. So, and it is a bit of a catch-22. So the concern is there are some medications that can, for example, dilate the pupil a little bit. And if you have narrow angle glaucoma, that can be a risk for causing an acute closing of the drain where the pressure goes up. So the thing is, if you know that you've got narrow angles and you've had laser iridotomies, then that in general will eliminate that risk from occurring in the majority of patients. So for most patients that have had iridotomies, they can go right ahead and take that medication. It's quite commonly seen, for example, for bladder medications, some antidepressants, medications in that category. So the patients that are probably at most risk for that are patients that have narrow angle glaucoma or the potential for narrow angle glaucoma, but they don't know they have it. So, and I've seen that patients that do get put on a systemic medication and they get thrown into angle closure glaucoma. But if you've had an iridotomy, it's very unlikely that you'll go into angle closure glaucoma. Now, some patients are concerned that, well, what if my iridotomy closes? Well, that was more of an issue years ago when argon laser was used for iridotomies, but it's almost never happens with our current laser modalities.
Okay, that's great. Great answer, Dave. I just put one more push to cataract surgery, I guess. If you've had a narrow angle and you've had cataract surgery, that will also lessen the chance of a medication affecting your glaucoma.
The only other thing to think about, if you need systemic prednisone or other forms of steroid, that has a risk of raising the eye pressure, especially if you have an underlying tendency to open angle glaucoma.
Yes.
Usually the need for the prednisone is such that has to take priority. And it just means you need to get your eye checked a little bit more frequently.
Yeah, and I would just always say to any patient, if you are concerned, check with your eye care professional first before you start any of these medications. Okay, so we'll start with some, boy, a lot of questions are starting to filter in. So next question would be, is it usual to have only one eye affected with glaucoma, and should you put drops in the other eye nonetheless? So I'll pose that one to Cindy. Cindy, do you mind answering that one?
Yes, well, thank you. First of all, Dave, thanks for the great presentation. You inspired me as well as everybody else. The thing about glaucoma is there's more than one type of glaucoma. There's many glaucomas. We can divide them as primary and secondary glaucomas, open and closed angle glaucomas. Most primary open angle glaucomas tend to be bilateral, both eyes, although sometimes they can affect one eye asymmetrically more than the other. But some of the secondary glaucomas, which means they're secondary to something else, they can be unilateral because whatever that is causing the pressure to go up may be only affecting the eye. We have something called pseudoexfoliation, and I think someone had a question about that. It's related to inheriting a gene called the lysyl oxidase gene. That may show up, first of all, in one eye and not the other. We have inflammation that can affect the eye, either due to a virus infection in the past, which may affect one eye. So there are reasons why one eye could be asymmetrically affected more than the other. Dr. Birt mentioned prednisone. Maybe there is a reason why you've been putting a prednisone or a steroid cream around one eye more than the other, and that eye will be more affected. So because there's many different types of glaucomas, it's possible for one eye to be affected more so than the other, and sometimes only one eye. And then Dr. Tingey mentioned, and Dr. Bindlish mentioned, there's the so-called closed angle glaucoma. Maybe it's a person who didn't have the prophylactic laser iridotomies, and one eye again went into angle closure, what we call subacutely, where the patient may not have realized they're having little intermittent attacks. So it is definitely possible to have one eye more than the other. Great question. Are you protected by putting drops in another eye, even if your eye care professional says you don't have the glaucoma there? I say yes and no. Sometimes I say to my patients, especially if the eye drop has a side effect, like making the eyelashes long, I sometimes say, you know what, because of the side effect, you might treat one and protect the other, especially if it's an asymmetrical type of glaucoma where both eyes may be inevitably affected. So again, you try not to over medicate people when they don't need it. But there's some instances where putting the eye drop in the other eye may not hurt. And it really is, it's a conversation with your eye care professional. I think, as Dr. Birt and everyone mentioned, regular checkups, monitor what you're doing, monitor the pressure lowering effect, monitoring if both eyes are now starting to get glaucoma, and keeping an eye on the side effects.
Okay, thank you, Cindy. Great response. I'm going to pose this question to Katie, Dr. Birt. My mother has glaucoma and has been recently diagnosed with ALS. Some of the ALS treatments can worsen glaucoma. Has there been any research being done on how other diseases impact glaucoma? And they understand it's a broad topic, so if you could answer as best you can, Katie, that would be great.
Yeah, so my sympathy about the ALS, that's a horrible thing to have to live with. There's a lot of interaction between the rest of the body and the eye, but I don't think there is specific research about any one disease. We know that there are some, sorry, the cat is my mental health medication, but she's a little needy right now. Some diseases are seen more frequently in glaucoma, such as diabetes and high blood pressure and so on. But I don't think there's specific research about some of these other less common ones. Generally, we'd look at the medication someone was on and try and treat based on the type and stage of the glaucoma in the setting of the entire patient's quality of life.
Okay, perfect. Thank you, Katie. Here's a question for Dave. If you get the spyglass implant, do you need your cataracts replaced every 2 years?
Well, you know, that is an excellent question, because that's exactly what I thought when I saw that. So generally, you know, when you have cataract surgery, it's good for life. It's not like hips. If you get your hip replaced and you're 45 years old, they'll say, boy, in about 15 years, you might have to have that hip done again. But generally, we view cataract surgery as a one-time thing. So that, I think, is a little bit of a limitation of the spyglass, in the sense that you could have it implanted, and let's say it controlled your pressure for 3 years. Well, that's great. 3 years is great. But if you're going to live another 20 years, what do you do after that? So generally, we would not recommend going in and removing a lens implant, because you can get into the weeds pretty quickly and cause more problems than benefit. But, you know, and I'm just thinking out loud here, but if I was designing this, I'd think, well, gee, is there any way you could fill up that reservoir again and give them another 3 years with a tiny little needle or something, without having to obviously take the whole lens out and put a new one in? So, you know, I really showed that just as an example of how people are really thinking outside the box in terms of giving us other options with medications. And, you know, the other thing, I can even remember seeing somebody from the industry talking about an implant attached to your cataract lens that would measure pressure, and it would use sunlight to recharge its battery. So this is almost getting into science fiction, really, but that's a great question.
Okay, great, Dave. Thank you. This is actually a really good question, and maybe I'll get Dave to answer it because he's the king of trabs. Katie's the queen as well, so both of them. After trabeculectomy surgery, there may be some scarring of the bleb. What adjustment procedures are there to deal with the scarring? So maybe we'll start with Katie, and then Dave can give a little bit more insight.
Okay, so the first thing is we're trying to prevent it by good surgical technique and using prednisone eye drops afterwards. Sometimes you need to increase the flow to keep the scar soft. So we would cut stitches using a laser just to melt the stitches in the deep layer of the surgery. If the scar kind of sets in too much, then it's possible to break it down and soften it by injecting some medication. They're derived from cancer medications, but they're not, we're not using it for that. We're trying to prevent the scar tissue from forming and to keep it from, and if it does form, to sort of stop it and break it down a little bit. And that's done by either a medication at the time of the surgery, which is just part of the operation, or one or two different medications can be injected into the scar as a very minor procedure subsequently. David, take it from there.
Yeah, I think I would echo all of those points. And we refer to that injection as needling, where we can inject medication to try and prevent and break down scar tissue. We can also use the needle to mechanically open things up. And then sometimes on rare occasions, we can even go back to the operating room and sneak inside the bleb and try and break down scar tissue with tiny scissors. But this is a challenge for us. Some people are much more prone to scarring than other people. And it's quite disappointing when you do a perfect operation and then Mother Nature comes along and decides that you're not going to win.
And can I just add, one thing that has been supported by the Glaucoma Research Society of Canada is innovation in the area of controlling the scarring. Just recently, the GRSC has supported grants that have looked at better ways to modulate the scarring, because as Dr. Tingey suggested, some patients scar very aggressively, but there's also occasionally patients who don't heal up quite enough, and they actually end up having very low pressures, which the eye doesn't necessarily like and appreciate. So one of the areas of active research is modulating that scar tissue after the surgery to prolong the life of and the success of the glaucoma operation.
Thank you, everybody. That was a great discussion. Obviously, for us as glaucoma specialists, we're always trying to improve our surgical techniques. So whatever surgery we do has a prolonged effect. Here's a good question with regard to patients with glaucoma. Can they practice yoga or any other sports and exercise? Cindy, do you have a quick answer for that one?
A quick answer. There's actually been a lot of research in this topic, and the answer is basically being in a lot of downward dog positions where your head's below your heart can put people at risk. But again, Dr. Tingey mentioned health-related quality of life. Yoga is very good for you, for your stress. So bottom line is you can probably practice yoga, but you have to make sure you're compliant with what your eye doctor tells you. Go to your appointments, have your visual field tests, have your nerve looked at, take your medications, and be monitored. So overall, I think your health-related quality of life is important. If yoga is part of that, keep doing it, but make sure you go for your regular eye checkups as scheduled.
Okay, the only thing I would add, which I think Dr. Tingey taught me this, was those patients who play wind instruments. So if you are a musician and you like to play wind instruments and stuff like that, you should be a little bit careful because that can cause a fair bit of pressure around your eye. A question, when is laser surgery preferred to eye drops, and when is a good time to switch? Katie, can you answer that one, please?
Well, you can use laser. I think Dr. Tingey mentioned at almost any stage in the treatment. It can be your very first choice with no drops at all. If one drop is working but not quite enough, you could add a bit of laser, and that may just bring the pressure down to where you want it. If drops work but aren't tolerable, you're getting allergies or side effects, then you can replace a drop with a laser. And then there are the more advanced forms of laser, which you tend to use in more advanced forms of glaucoma. So like almost everything we do in this business, it depends. You have to look at the individual patient. There isn't a formula that we apply sort of regardless. You have to really match what you're doing to the needs of that individual patient.
Yeah, it's a tough goal to decide, and I mean, trying to pick one treatment for that patient is sometimes can be a little bit more challenging. Dave, I'm going to put you on the spot for this one. I think it's a good question, but what does Dr. Tingey think? I would think they're talking about MIGS therapy because it's microcurrent therapy. So I'm assuming they're talking about MIGS. So what's your opinion on MIGS?
Well, as I said, MIGS is welcome because although, we do a lot of trabeculectomies and they're great, they're hard work, they're fairly invasive, and they're not without risk. So we've been looking for simple, less invasive procedures to help control pressure. I think there's two drawbacks with MIGS. One is a lot of them don't really move the needle a lot in terms of pressure. They get you a little bit of pressure lowering, or they might let you get rid of one medication. And the other is they're prohibitively expensive right now. And in our medical environment, it's a challenge getting them into the mainstream for patients because we can't ask patients to pay for them. They're prohibitively expensive. And there's always a little bit of pushback in terms of hospital funding, because they might argue, well, this costs a lot. Is it really doing that much? But nonetheless, I have no doubt that they're going to continue to expand in terms of their use. And, from a quality of life point of view, again, if it can reduce the burden of medications, I think it's welcome. But, it's a very confusing field right now. There's a lot. The thing is, it's very easy to get a device to market, and there's a lot of devices that are appearing on the horizon. And I think all of us are kind of waiting for the dust to settle in that regard.
Yeah, and it's one of those, and some people, the procedure works very well, and others it doesn't. Surgical technique is very important. And that's sometimes why when we say it didn't work, it might be more related to the technique as opposed to the actual device. This, I think, is a really good question. I'm going to give this to Cindy. Have you heard more about insulin treatment that's reversed visual field loss? This was discovered by Dr. DiPolo in Montreal.
Yes, no, that is certainly a treatment that has actually gone maybe even beyond the research realm. It's interesting because, as I mentioned with my other question, there's probably more than one type of glaucoma. And I know some of the questions have risen about this whole entity of normal pressure glaucoma, highlighting that glaucoma really is a nerve disease and not really a pressure disease. And maybe lowering the pressure, which we know is an effective treatment, needs something else to kind of neuroprotect. So yes, and the whole idea there is that insulin has some putative neuroprotective effects. And it may be in some patients having a benefit. I don't know strongly. It's certainly, I don't think at this point, nobody really knows what causes glaucoma. Nobody knows how to really cure glaucoma. And we keep searching for that golden grail of a neuroprotective agent that would make those retinal ganglion cells that Dr. Tingey talked about resistant to either high pressure or low pressure. So yes, it's out there. The research done by Dr. DiPolo is outstanding. She's internationally acclaimed for her research that she does. And it's maybe one of those promising elements that may in some patients have a benefit, may not. So I think time will tell. And it's again, the area of research, the type of things that the Glaucoma Research Society of Canada supports, and exciting to know that this might be part of the solution.
Thank you, Cindy. This question always comes up, so I'll just quickly answer it. It's THC in cannabis as recognized a means of reducing eye pressure. Right now, the position by the Canadian Ophthalmologic Society and the Canadian Glaucoma Society is that we do not recommend the use of cannabis, whether that be the THC component or the I can't remember the other one, but there's two components to cannabis. One
CBD.
is, pardon?
CBD.
CBD. So CBD is more for pain control. We thought that may help lower pressure, but it doesn't. It's actually the THC, and the THC is actually what gives you the psychogenic effects of cannabis. So because of that, we don't recommend using cannabis as a means to reduce eye pressure. I think we're going to wrap it up here. It's 7:59. There are still a fair number of questions, and maybe some of us can address some of them. As we were answering questions, more and more kept coming in, and it's always going to be very hard to answer everybody's questions. So I'd like to stop there. First and foremost, I'd like to thank Dr. Tingey for his excellent presentation. I just remember as a early glaucoma person, someone to always look up to. It was always Dr. Tingey. He gave the best advice possible. And he always encouraged us as junior glaucoma people to keep going, never get rattled, never get phased. He's like a real rock in the glaucoma community, and he's just been a great mentor to all of us. So thanks for this great presentation. It was amazing, and I hopefully informed all of our attendees, and we had a record number of attendees. They stayed right to the end. In terms of giving you an overview of glaucoma. Lastly, I'd just like to reiterate something Dr. Tingey said, is that there are new treatments on the horizon, and that is the future of glaucoma care. But those new horizons and new treatments, we don't know what they are, and we really need your help in supporting the Glaucoma Research Society of Canada, because those funds help researchers like Dr. Hutnik, like Dr. Tingey, like Dr. Birt find these treatments. And they can be anywhere from simple things like medications. There's always a lot of questions about stem cell research, and you could be funding projects like that. So please give your support, and we look forward to you joining our next webinar, which would likely be next year during World Glaucoma Week. And we ask you to tune in as well to our annual supporters meeting in the fall, where we will have another glaucoma presentation. So thank you all, and with that, enjoy hopefully an early spring if we can get that to that. Thank you.